everyone, and welcome to MedEdge. I'm Marcus Grimm. This is a quick reminder that MedEdge is brought to you by Medtrix, which is the premier student, resident, faculty, and administration engagement platform for both UME and GME. Learn more at medtrixlab.com or from my frequent co-host, and he's here today, emergency radiologist and Medtrix CEO, Santosh Cherian. How are we doing today, Tosh? I'm
doing great. Every time I get on this call, I'm excited.
Well, Tosh, here's my first question for you. I'm going to start by putting you on the spot with a reminder that a guest is listening in. You and I, we have fun. We at the risk of discussing stereotypes, I think we both agree there are some informed generalizations we can make when it comes to medical specialties. Look, we've talked about surgeons, those sometimes maverick tendencies, which enable them to save countless lives. But it also means they could be a little bit slack when we're asking them to get those residency evaluations done in a timely manner. Tasha, you've talked about how your own journey into radiology was really informed by not just the type of work that you wanted to do, but the type of person that you are. So, Tasha, I'm going to put you on the spot here. On today's program, we have an oncologist. What do you all say about oncologists when they're not in the room?
When it comes to oncology, what I've heard and what I've experienced is they're usually very empathetic patient individuals, because going into that specialty requires you to really understand human challenges and human suffering and be patient throughout that phase. It's not something that everyone can do. I can say it is not something that I can do. I'm an emergency radiologist. I don't work with cancer patients at all. I do trauma and whatever cases come through the emergency department. Sometimes we run into cancer there, but it's a whole different world where you're dealing with the patients over long periods of time and being there for the patients and their family members. That's what most individuals would say about oncologists.
Yeah, and I think I found it, incidentally, I think, we've all at some level, whether we've experienced cancer or we've had a relative go through it, I think that your description is probably an apt one, but let's see if it holds up today. Today's guest on MedEdge is Dr. Hardeep Phull, who is the Director of Oncology and Infusion Programs at Palomar Health, Director of Medical Oncology at Palomar Health Medical Group, and a board member of the Palomar Health Foundation in beautiful San Diego. He's also a clinical instructor at the University of California, San Diego School of Medicine. Hey, listen, our audience is made up of everyone in the UME and GME community, so let's rip through those NASCAR logos. We've got a BS from the University of Arizona, a medical school at the Cleveland Clinic, Lerner College of Medicine, internship residency at the Scripps Green Hospital, and a fellowship in hematology oncology from UC San Diego. Looking for a little bit more? We hope to get to it on today's program. Hardeep is also a licensed pilot and travel blogger. Hardeep, welcome to MedEdge.
Hey, thanks, Marcus. Thanks, Tasha. Thanks for talking behind my back about what you think oncologists are. Tell me what you really think.
Yeah.
I love that. That's great. And Tosh stole the line from me, but I do think one of the words that we always come up with when it comes to oncology is empathy. In fact, I'd argue that when patients express their frustration with medical professions' lack of empathy, I feel as if those stories are rarely about oncology. So many times people go through cancer, they are amazed by not just the care they receive, but the compassion as well, which is huge. And I'm curious, it's sort of a chicken and egg thing, right? Is it nature? Is it nurture? Hardeep, you've been an oncologist for quite a while. Does oncology attract a different type of doctor? Or is it one of those things that, we've got UME and GME listeners to this program. Do they put more of that training, that empathy into your training, or is it something you're born with? How do you think about it?
I think empathy is innate. I think you can tap it. Any one of us can. I don't think you need to be a first responder or a healthcare professional to have empathy. I think it's a skill you develop. And to be honest, it's not taught enough in curriculums or even school, even primary school. We're taught to learn book knowledge, transmit that on exams or solve problems. And I think we're taught that as a soft skill, but no one really realizes, oh my gosh, that's one of the most important skills, not just for helping others, but also helping yourself. I think as an oncologist, you get more exposure to it, so you get natural opportunities to practice. but I also think in oncology, you get so many pressures and burdens to lose that very thing you're supposed to be getting, because the immense pressure and the current climate in healthcare, which kind of robs doctors of empathy, to be honest.
Absolutely. And we're going to be talking about that a lot today, but let's stay on this topic for a little minute, because Tosh kind of gave me a thought here. He said from the jump that, oncology wasn't right for him. We love to ask about your choice of specialty. Talk to us about that. You were going through medical school. You get up to it to where match day comes, and that's sort of where you have to rank order. How are you drawn to oncology in the first place?
I'll say that my first volunteer experiences in high school were actually in oncology. My mom is an oncology nurse, but she went through many different specialties before that, and I found that to be the most rewarding. So my high school, formative years in the summers when I was volunteering at the VA hospital in Tucson, Arizona, was formulated of sitting with cancer patients during their infusions and just talking to them. I did not understand the biology. I didn't know what they had. No one really told me, hey, patient X is here for this treatment, and here's what they're getting, and here's why. It was just spend time with that one. He's going to be here all day. He's kind of lonely. Talk to him, listen to him. And it meant listening, really learning. And that's where you pick up listening skills, really, by talking to people and talking to people from diverse ways of life. Now, with that said, these were all like war veterans, usually World War II. Elderly VA veterans. So I got a very interesting perspective. Maybe some inappropriate stories you should be telling a high schooler. But, looking back, the real world is, that's where I learned it. But to be quite honest, despite that, after that, I decided, I wanted to do surgery, and I was doing a couple of research years after graduating college in a urology lab, and in a very lucky position where literally I was like the lab manager, and we had urology residents coming in every 8 months who were very talented, but didn't have time to, let's say, write up publications or present them. So I got to have the best of both worlds, organizing research projects, writing grants, writing papers, presenting, to the point that when I applied to med school, I had 7 papers already, which is very rare usually at that level. So it made me almost like a research candidate, which actually hurt me at first applying to med school, believe it or not. Because then they're like, are you sure you want to do human medicine? You're really good with mice and pigs and lab experiments.
Right.
So you then have to reinvent yourself how you say that, in your personal statement. But anyways, long story short, Cleveland Clinic was one of the first med schools of its kind, small classes, all about problem-based learning, back when that was a thing, like a new thing. No tests, no exams, by the way. No tests, no exams. Do research, become a physician investigator, write a lot of portfolios, write a lot of papers, publish, and develop on your own. And they gave resources and lectures, but no exams. And it was so hard when I entered med school to do that, because no one's used to just learn on your own. That's just the way it is, because you want to know the fundamentals. You want to be spoon-fed, right? And so I remember how frustrated I was the first 2 years of med school. And, when the boards came around, most of us hadn't taken a single test in starting med school. And so,
wow,
going forward, I didn't do as well on the boards as some others, although my class as a whole did really well. They probably just selected people who were very good at test taking and who were also very smart. We're self-motivated people. But to be quite honest, that's about the level where I started re-questioning myself. Not that, my scores aren't good enough, I can't be a urologist, but is this what I really want? And I'm in a school now where they're telling me, don't just do things because you can. Look at your skills and develop yourself. So it was literally up to the very last rotation in my last year, near fourth year, when I'm about to apply, and I did an internal medicine internship, AI, and I decided that at that point, wow, my skills match medicine far more than surgery. And, in urology, I was doing mostly kidney cancer research. So I said, maybe I should be a medical oncologist. But I was also looking at GI at the time. So you say I didn't have it figured out. In retrospect, I do. But prospectively, I was a nervous wreck going into match day. And, getting into my program was just one step because I was at a research track with internal medicine, but I didn't know what I wanted to do after. And so even then, it was the end of my second year of residency where I said, oh, you know what? I really like med-onc. How come I didn't like this the whole time? That's what I started my journey with. So it was like a full circle. I'm really happy it happened that way, but it wasn't planned. And I wish I was as intelligent to plan it out, but it wasn't that way.
Yeah, I'm curious. Do you ever have a sensation? It's interesting to me that you said, my earliest experiences were in oncology, and then I kind of drifted away, pushed in different directions. Do you ever look back and say, well, maybe I just should have listened to that 17-year-old kid? Like, he knew what was best for me.
Sometimes, but to be quite honest, that 17-year-old kid was naive and innocent and didn't really know what he wanted and wasn't as mature, had empathy, but didn't know all these terms. And to be honest, it's a journey. And when you learn these things and interact with people, interact with experiences, for example, one of the most rewarding experiences in college was going abroad for a semester. I had a research project in Poland where I got to meet some amazing people and went to a whole new country where, people didn't speak English most of the time. And I remember walking out in the streets of, I was in a town called Bydgoszcz, and I was like the only dark-skinned guy. So I'd get all this attention and people walking up to me and asking me where you're from, and really kind people. You can't learn that in a textbook or a hospital room or nearly anywhere. So I tell students nowadays, have a diversity of experience. Don't just do pre-med, do something else, even major in something else, for God's sakes, because you'll have your life, the rest of your life to do that. Do something unique that'll define you and differentiate you and give you hobbies, God forbid, one day. So you don't just have to have medicine.
Tosh, you've had some unique experiences as well. What are some of your thoughts on what we just heard there from Artie? But it's you get that idea as a 17-year-old, this is what's right for you. But that's instructive. But to Hardeep's point, should that 17-year-old really be planning the rest of your life? What are your thoughts? How would you reflect on what we just heard there?
I agree with what you're saying about having that diverse experience. There are some individuals that find and think that they want to do a certain thing and it lines up the whole way and it works out really great. But for most people, especially as you go through your teenage years and your college years, you want to have that experience. Otherwise, you're simply limiting yourself to what you can achieve. For example, myself, I think I spoke about this on a previous episode. I did not want to go into medicine at all. I started college doing biomedical engineering, and then about a year and a half into it, I ended up working for a software company implementing EHRs at hospitals in Manhattan. It was a way to make money. It wasn't really anything fancy, but it put me right next to doctors that were taking care of patients, and I was following them around and helping them click buttons on the EHR. But it gave me a really new perspective on medicine because my mom was also a nurse, but I didn't really have any physicians that I knew. So that was my first real exposure to being next to a doctor and seeing what they do. And then I changed my major to applied math and finished my degree and did my pre-med courses. So if I had not taken that job, if I had not been put in that place, I probably would have stuck with whatever degree I was and gone down a whole different path. But taking that opportunity and talking to people led me to medicine.
Right. Hardeep, I want to ask you, when we saw you were an oncologist and we saw your work on LinkedIn. By the way, Hardeep runs several groups on LinkedIn. I encourage our audience to check out all of them. But that word empathy comes straight through, and it certainly is at the heart, I think, of everything that happens in oncology. That being said, one of the things that I've learned about empathy is it's really difficult for anyone, physician, nurse, someone like myself, some marketer. It's hard to practice empathy if you're not personally in a good place. So we're going to take a hard turn right here because let's face it, lots of times today in medicine, we're not in a great place. You've been called a physician advocate of wellness in your institution and community. This concept of physician wellness is an emerging one. And obviously the casual audience can say, listen, the doctor's there to make me better. Yeah, but it's that whole airplane analogy. You need to put on the oxygen mask on yourself first. And when we talk about physician wellness, it's often thought of as a strategy to counteract physician burnout. But we all know that words matter, right? And in your work, you've introduced an alternative term to burnout. What do you prefer? Sort of walk us through how you think about the burnout.
I think burnout is just a common theme in any industry. It doesn't have to be healthcare. Problem with that term is thrown out, and it kind of implies that we as individuals or employees lack the resilience to perform the work at hand. And so you shift the problem somehow to reside within that individual who's deficient. That's kind of how it is. Oh, you have burnout? Oh, here's some wellness, here's some yoga for you. Sorry that you have burnout. In contrast, moral injury, which, by the way, has been proposed since decades, but becoming more of a popular term now, many leaders in healthcare, bloggers, podcasters are using that now. And the reason they use it is moral injury really, it goes back to war zones. We talk about the VA hospital and so forth. It's literally the fundamental disconnect between the needs of, let's say, an employer or healthcare system. And it's not necessarily like intentional, but it's the needs of, let's say, a system, whatever the needs are, their financial and other needs, as compared to an individual's passion, motivation, and moral beliefs to serve patients. Oncologists have some of the highest levels of empathy, you just mentioned, humanity, resilience, emotional intelligence. I talk a lot about emotional intelligence just as much as empathy. The idea of not just being book smart, but being, street smart, and also having social skills. And oncologists develop this because they see people in very emotionally draining, vulnerable positions in their lives. So some of the most vulnerable, you could say. And it's a privilege and honor to have meaningful relationships with people who are suffering. So we empower people to go through that journey. We go on it with them. And so you have that empathy for a person. But when you have a system, let's say, that contrasts with your ability to provide care or provide emotion and support because you yourself are burned out, that's when I think you get this cyclical kind of moral injury. And that's what I think leads to actual mental health issues, attrition, doctors leaving the field, not just oncologists, all kinds of doctors leaving the field, reinventing themselves. And that's not bad to reinvent yourself, but they're finding alternative careers because the initial thing that they had a passion to go in for is no longer providing that same level of, let's say, purpose.
It's a great answer. And it makes me think my next question is wrong, which is why I love to do this show. I love to write questions and have people like you sort of reframe my thinking. So when we talk about solving problems, we first need to understand them. And so my question that I had for you was, where are we seeing more moral injury among younger physicians or older physicians that have been perhaps in it too long? But what I kind of hear from you saying is, Marcus, you probably shouldn't be looking at age or specialty. You should probably be looking at the system that they operate within. Is that kind of how you think about it?
I think so. And I think, I don't want to use ageist terms, but I think physicians who've been in the field longer, especially under a different training model where, let's say, they didn't have work hour restrictions. For example, I trained at a time when we were just entering that phase, and I was still working 24-hour and greater shifts. And nowadays, that's kind of very rare. It's more shift work, more fragmented. And there's kind of this insidious judgment that goes along with doctors who did it the old way and doctors coming in the new way. Even though the new way is about mental health and avoiding burnout and wellness and starting wellness early. But, it's considered, again, we mentioned a soft skill. We mentioned it's considered soft. And you didn't go through the rite of passage I did. I remember when this was becoming very common and discussed more. And I remember actually a physician, I forgot who it was, who wrote an article, I think even in the New England Journal, where they said, We are just pilots that are coming in and doing shifts on an airplane. We're fighter pilots. We're expected to stay up all night and go fight a war. And I thought, like, what a terrible analogy to tell someone starting medicine. Like, sorry, but that's just what you're asked to do, and that's what you're supposed to be a fighter pilot. You can't be a regular pilot. But I mean, you can be a great doctor and do great things, but you're a human being, and you have to have sleep and food and rest and time to relax and unwind. So in a way, I'm glad I went through that way in a transition, like that way of training. But it's even for me, I've used terms even in this conversation. I said, oh, the current training is a little bit fragmented. You see how judgmental that sounds? Yet, even though it is to some extent, they didn't get to experience the full gamut of what abuses you can have as a trainee. And I'm glad I had some abuses in the sense that you really get to learn your limits and what you're capable of and how to operate under stress. But when that system keeps perpetuating and you never get relax from it and you just push it under the rug for decades, then you end up being a physician who has no, they might have empathy, but you've brushed that under the rug too. You've compromised, and you may still be a great physician, but in some way your soul is hurt. That's a moral injury. And some people deal with it better than others. Now, there's also the other idea that, you're giving people this kind of excuse to say, oh, I'm burned out. I need an off day. And so there's again that balance. Like, yes, you have to work hard, and yes, it's going to be hard. There's going to be times, let's say you're going to cry during training. That's normal. You should, as a human being who goes through that, especially dealing with dying patients, have that. So don't rob people of natural experience and hard work and determination, resilience, etc. It takes being brought down to rock bottom to build yourself up. I think I mention this a lot in my posts. Failure is a part of success. You can't have success without that failure. But all I'm saying is make it in a system that's a little more focused on wellness from the get-go. And I think people are trying to do this. But again, it's this conflict between rite of passage. I went through this, therefore you should, as compared to let's reinvent what rite of passage means.
Tashi, you and I have spoken about this, but before, not only do you work in healthcare, your wife also works in healthcare. Would you also agree that when you think about burnout, no, it isn't really an issue of generations or specialties, but more of a concept of it's the system that you're within? Is that how you think about it?
Yeah, there are two things that I want to point out, and everything that you're saying, Hardeep. One, I love the way that you phrase these things. You're very articulate in how you communicate this type of topic. So I think there's a couple of things that, one is that compounding self-doubt that happens. And then part of this also, like you pointed out, the language really matters. The word burnout, you're pointing it out as your fault as opposed to the system. And even the word empathy that we talked about earlier, the fact that we call it a society as a soft skill. Soft is opposite of tough or hard. And so when I see that often sometimes in the younger individuals, it's almost, you want to be tough. So why do I need soft skills? But it's not really a soft skill. It's really a strength that you can connect with people and influence and become a leader. But I think the language kind of downplays the importance of developing that empathy.
I agree.
I want to twist around some of Tolstoy's words. He said all happy families are alike. Let's say all happy physicians are alike, but every unhappy physician is unhappy in their own way. And I'm curious, is that true, Hardeep, or when you look at the types of physicians that are experiencing more moral injury or burnout, are there actually hallmarks where they're working where you can say, yeah, I can kind of see how this environment is impacting where they are? When you're trying to figure out the root cause of how we improve physician wellness, what are you looking for?
First of all, no one's all one thing or all another thing. They're not all good. They're not all bad. They're not all burned out. They're not all happy. I think, in general, oncologists and physicians keep their head up. That we do have resiliency built into us. I think physicians try to have a sense of duty purpose, resilience, even joy. We get accustomed to the administrative chores we do. Another thing to write about is the EHR and the wonderful things we get to do in the EHR and how we just joyfully do them without asking any questions. Why did we agree to have to write so much filler and things in our notes just so the billers are happy? But that's a whole different topic. I think what ends up happening is once things go out of your immediate control and you erode that journey, you get close to this edge of becoming cynical, depersonalized, losing empathy, and not just for others, for yourself, right? You stop being an advocate for yourself. And the thing is, none of us are superhuman or immune from breakdowns. But in medicine, when you have a mental health issue, it's thought to be kind of a bad thing. You could lose your license over it. It's almost like a threat if you had that. What's wrong with me? And it's sad, but females in medicine have it the worst because they're not just doing medicine. They're doing a lot of family things and they have to take breaks. And I've noticed even in my observations of females that I work with, who I advocate for, by the way, it's a double standard. To be quite honest with you, there's no easier way to say that. It really is. And then you add in compassion fatigue and work habits and worsening physical factors, and then you add in childcare to it, and basically having a life where you have to pick up, kids and drop them off. And yes, husbands help with that, but my female colleagues, they're holding it together at home. That is a hard thing to do, even on its own, without medicine. And so when you add that, then you add the loss of autonomy, then you add really sick patients and the inability to take care of them well because of whatever reason. Let's just say insurance prior authorizations, another topic I love to write about. You start adding all these other factors, and it doesn't take much for you to wake up and say, "Man, I did not want to go to work today," and it's an erosion. It's an erosion and detachment, disconnection from yourself, from others, and what was once a rewarding duty now gives way to like detrimental feelings of personal failure, injury, imposter syndrome. Love talking about imposter syndrome, and even mental health and depression. And sadly, most just brush that under the rug because you don't want to mention that word, God forbid, to someone at work. And then you're put into a special, wellness committee, or you have to see a psychologist and talk about your feelings. So again, that's important that you're labeled, and that's what's not good about it. It should be more of a resilient workforce where it's not punitive. It's rewarded to be honest and help us provided where you need it.
At the risk of being flippant, I'm going to tell you that I feel as if you just gave us a very serious diagnosis, and it's not a great one. So, but I know you're a healer. So how do we turn the corner on that? How do we start to improve things? First at the system level, my expectation is we've got listeners of this program going, "Yep, he just described our practice. He just described our audience." My next question is going to be about you, Hardeep, and how you deal with this personally. But how do we fix this at a system level? And I know we're not going to fix it on today's podcast, and I know it's not easy to fix, but how do we start?
To be honest, like I said, I mentioned earlier, you have to be excited about going into work. I think most of us love what we do, right? I woke up early and did this podcast. It's not necessarily for work, but I love talking about this stuff with other people. That gives me purpose and passion. It doesn't matter what time of day it is, how tired it is, how tired I am. I enjoy doing this. As long as we have that joy of wanting to go into work. And so that means making the work culture, the workplace, a safe place. Bureaucracy will always exist. There's always going to be a need for that. There is a financial side to medicine. Health systems should be profitable. They can't lose money, can't provide care if you're a losing entity. So you have to balance those things. But you really have to look at a person as an entire scope of a person who has duties and responsibilities, family duties, the need for physical activity and fitness, childcare, family obligations, sleep, stress management, breaks, right? My medical assistant, for example, every 2 hours is required to take a 15-minute break. Why am I not required to take a break? Who's decided that I'm so great at managing myself that I don't need breaks? Or lunchtime. my staff have to clock out and clock back in. And it has to be at least 30 minutes. Why am I sitting at my computer catching up on notes? I look outside, it's sunny in California most of the time. And I always bring my shoes to go for a walk or a run. But why do I make an excuse and not do it? It should be mandatory. It should be like, no, you got to clock out. Your computer's off now. You can't catch up. Nope, you're not supposed to do tumor board or call anyone or do anything else. This is your time. You're supposed to take it. For a forced break. And then there's forced wellness, forced contrived initiatives, which are well thought out, but unfortunately don't work. I once, during COVID, had a very thoughtful gift from the administration. Every doctor got one. And it was an empty water bottle with a packet of, I think it was pink lemonade powder. And they said, I know this sounds kind of cheesy, but rather than regular lemonade, we want to give you pink lemonade and tell you, when life gives you lemons, make pink lemonade. And I know what they're trying to do. They're trying not to be too stereotypical or whatever and cheesy, but at the same time, it was almost like a waste. It was almost insulting. But they couldn't do nothing because people were burning out. It was middle of COVID and we needed something. And we couldn't go out and socialize together, right? Like we would. So it was a thought. And it was, of course, they knew, like, what else can we do? That's not a great gift, but we have nothing else that we can think of that's creative. But really all they had to do was say, forced 30-minute break, go back and get some purpose, get some sunshine. And that would have meant more than that. Or let's say Amazon gift card. Thanks for the gift card. It's not going to make me feel more happy going into work today, The other thing we can do is, empower our workers and employees around us to also recognize symptoms of burnout, or let's say empathy for each other. I really go into work to work with colleagues and have fun with them. And that's interesting. Not everyone goes to work and says, I'm going to go have fun with my colleagues. I'm going to go joke around with my friends at work. And that's such a beautiful thing that I have, to have a work culture where I enjoy the people I work with. And if you have just one bad egg, someone who's not doing well, very easy to label that person and say, let's stay away from that person. They're making it toxic. But yet your job could be literally, while you're feeling well, make sure someone who's not doing well, is heard and empower them too. So you create that culture and a work environment where everyone likes what they do, even if it's hard, even if there's oncology patients dying every day. You create purpose and you create happiness and a willingness to want to go, So there's no easy fix, to be honest.
Right. But, there's a lot of great things you said there. Obviously, it starts with the passion and for doing what you love. The second piece that I heard there was, and I think our audience really appreciates this. You bring the shoes every day, but you admit, you come up with excuses for yourself. Like at a certain amount, you have to look in the mirror and say, how can I be part of the solution too? I want to spend just a couple minutes. One of the things that's always fascinating to me is how we see things in one specialty that maybe can inform what's happening in other specialties. As I mentioned, I think people that have gone through the oncology experience will say there are things that take place in the process. We have, as a specialty, I feel as if you have baked more empathy into your processes than we see in some specialties. How does that happen? What happens in oncology from a process perspective that perhaps other specialties should look at too for inspiration?
Again, I think if necessity is the mother of invention, you use the C word, cancer. I have patients who don't even have cancer, but they're seeing me for what they think is that, or they have a blood condition, and I'm a hematologist and oncologist, by the way, so that's two boards, two specialties, but they're seeing me for the hematology part, but no one told them that, and think they're seeing me for cancer part. So expectations, and it really starts at the level of telling someone you're about to see, the referring doctor telling the patient why they're seeing me, what is the purpose for this, and if that's not happening, there's very little I can do. I can sit with the patient and explain, but I have to walk them off a cliff. And so it starts at multiple levels. I think it starts educating patients. Okay, here's what you got and here's why. And you're going to see this type of doctor. You'll be okay. 90% of the time, it's going to be you'll be okay, even if there's chemotherapy and treatment involved. But naturally, people have fear, right? It's a natural reaction. You do not want to hear that word, the word cancer in any form. And so really it's empowering that person to overcome the fear, but also allowing them to go through the regular emotions any human being would go through in an area of, when they're feeling fear and vulnerable. So to me, it's just, it took me time to realize this, but it's just literally listening to the person and their journey and just empowering them. It doesn't happen on the first visit. Showing them the confidence you have in them and delineating the process that's about to happen and what's next. And I think most patients just want a checklist of what to do and get it done quickly because it tells them they're doing something about it.
Right.
So in many ways, I don't think a person is weak for feeling that way. And I don't think I'm so good at empathy that I'm superhuman. I think it's just meeting people on their terms where they are in the journey and recognizing that and just empowering them to work through it. And of course, some people do it better than others.
Sure.
There's some who are extremely anxious, and no matter what you do, will remain anxious. But overall, I think over time, it takes time in a relationship to help them.
That's really well said. We're running short on time here. I do have a couple questions that I want to sneak in here, but before the end, the first one that I have to ask you about is you are a physician leader, and that's an interesting topic as well. When we talk about the difficulty that arises when you're trying to practice medicine while you're leading other physicians, it's not easy to do both. And by the way, I think that applies in all industries. For years, I've always heard a sales manager shouldn't be selling, like they should be managing other salespeople. The argument is that the argument that perhaps some healthcare systems have is, well, Hardeep, the way for you to maintain that empathy is to make sure you're spending some time on the front lines. But Tosh and I had a great conversation with Dr. Lee Scheinbarn out of Florida recently, and he really poured cold water on that idea. And he said there's leadership and there's practice. And he actually introduced a nice term. What was the term, Tosh? It was shared suffering by physician leaders having practice hours. I'm just curious, Hardeep, you're kind of in a similar place right now, right? I get the sense you're still seeing patients, but you're also leading. I'm just curious, how do you think about physician leadership? Can you do both well? And is it in fact vital for you to be seeing patients to maintain that empathy? How do you think about that?
I love that shared suffering. I'll enjoy that. I think it's so important to have the pulse on the clinical practice and see what modern healthcare is like and what's going on today and currently at the institution. And I do believe the only way to do that is clinically to commiserate and understand, have empathy, let's say, for the physician. So I do believe in that. Also, most people have to keep their credentials up, right? You have to practice to some extent. So there's more valuable practice and meaningful. Like I see patients 4 or 5 days a week. So my leadership position is a little not full-time. But if you had a full-time leadership position, especially if you're a physician, I think it's so important to reconnect with that initial reason you went into medicine, first of all. But I do agree with this concept of understanding the pulse of your doctors at the front line. My mind keeps to try one saying provider, and I also don't like to use that term, by the way. I think that's another term that's endearing. It's not a good term. Call them what they are. But I think you do have to understand your practitioners or physicians at the front line. And that's a level of empathy that happens only through practice.
Right. We were, as Tosh and I were talking before the show about topics we wanted to make sure that we address with you. Tosh had a fascinating question as well. And I think this question is kind of funny because Tosh was talking about your interest and commitment to flying. And Tosh, of all people, goes, wow, that's a tremendous time commitment. This is Tosh, who is an emergency room radiologist, who's a CEO of a tech company. So Tosh, I kind of feel like you were the pot calling the kettle black, but you had a question for Hardeep about that.
I thought that was fascinating. I don't meet a lot of physician pilots, and would love to hear more about how you got into it and how does that help you with being a physician. Because for me personally, working on the tech side is sort of balances out my clinical side. It's a completely different way to approach my work, and it allows me to be creative and do a lot of things that sometimes I don't get to do in medicine. So I'd love to hear how flying helps you and how you got started with that.
I grew up just dreaming about airplanes. If I ever flew an airplane, I was like this 7 or 8-year-old kid dressed up, the nicest dressed up passenger, because I thought it was a privilege to fly, sitting on the window seat, thinking of all the things going on and why, and just staring out the window. Some people during an airplane flight are putting down the window shades, and I'm the one putting it up and making the cabin way too bright when someone's sleeping, because I just love looking out there and just thinking and realizing how beautiful it is. I was born in the 80s. Top Gun was a big thing. So I always used to love that movie. I thought about it even, should I become a pilot or fighter pilot? But, at the end of the day, it became a great hobby, and I didn't even know I would do it. I literally had a few years off, like I mentioned, where I was a lab manager in urology, and a little extra cash, not a much, but a little extra cash on my hands. And instead of saving it for med school, I said, I'm going to get my pilot's license. And it just happened one day. Like, I didn't think about it or I'm going to do this or anything. It just happened. Like, you know what? I'm just going to go to that airport. There's a little there's like a $99 introductory flying lesson. They give you this little certificate, and, it doesn't really do anything. But once I did that, I said, okay, now how do I do actual lessons? And I had to take out a little loan and do it. And I would do it at 6 a.m. every morning, a few times a week, do these lessons with a flight instructor, and absolutely loved it. Couldn't wait to get up and fly. And beautiful Arizona too at the time. You see the sunrises, just outstanding. And so it went from that to, getting my private pilot's license, and then realizing I don't have any money to buy a plane or to fly really that much. So I would just split up, these local sightseeing flights with my friends, and, kind of silly. Like, I was just flying in circles literally near the airport. I never really went far from the airport because couldn't afford it. It's like even back then, $120 an hour in those dollars. Now it's like hundreds. So it was good. I really loved doing it. I did a little bit of it in med school, but I got way too busy. And after I met my wife, I wanted to take her once. So we went in the Bay Area a long time ago. And people say, have you flown since? And I say, not really. And the reason is I'm not current. And one of the biggest things you have to do in flying is to realize your limitations. You can't just turn it on like a car and go up and come down. You have to really know your airspace, your aircraft, to be current. And so I would need at least another 10 hours of instruction if I did it right now.
Right.
But yes, I do plan to do it. I have younger kids now, and I do believe it's safe. I don't think it's a lack of safety. I just think my mind's not in it. I have way too much on my plate. The doctors who get into plane crashes and accidents are the ones who are not physically present or mentally present. There's a lot that goes into it. I post a lot about that, in fact, how pilots and doctors share similar things. They're under pressure. They can use checklists to help them stay on track. They can use the perspective of aviation to look down at the world and, surpass the boundaries. Literally when you're flying an airplane, right, you see a bunch of squares and circles and, especially in the rural areas, like, oh, there's all those fields, but you also see roads and you see boundaries. And I always talk about how aviation transcends boundaries. You see how silly we are, looking down at a 2D world, and we're in the 3D world. It's like, look at those silly humans down there, like ants just going about their business. So, you get that perspective. But to be quite honest, to me, beyond that, it's not like I'm actively thinking. I like to write about that. But when you're actively up there, it's not, oh, look at the perspective down there. It's more like, damn, this is so cool. I can't believe I'm doing this. How could I go faster? It's like you feel like, like in a Top Gun movie, you're like, wow, I wish I could fly, in Mach 7, Mach 8. It's literally just a obsession with the spirit of flying, which also I think is innate in all of us. Because you see, Leonardo da Vinci saw, birds and tried to make something like a little bird device to fly. Everyone wants to be up with the birds and soar like eagles. It's like a human endeavor, right? For the longest time. So it's just a pure privilege and passion, and I get so much joy. I get joy from the technical parts of it, even just the instruments, the engineering, it's just so cool. And I remember one of my proudest moments was taking my dad for the first time. He's an engineer. And I literally surprised him. I just said, oh, we're going to go for breakfast, and just took him to the airplane. He's like, what are you doing out here? Is this allowed? Is this safe? Do you have clearance? Like, are we going to get arrested? I took him to an airplane. Like, don't touch that thing. What are you doing? You don't own that plane. I said, no, I'm going to take you up flying. And then I showed him my license. And he was just so proud of me because he's an engineer, and he was looking at all the dials and instruments, and I was showing him what I'm doing and why. And so it was a proud moment. And so I like that technical aspect. But truly, there's so much fun in aviation. I tell everyone, take at least a lesson. It's just so much fun to be in the cockpit. You learn so much about yourself. You get confidence. You do something totally out of the world. To give you an idea, no one else on the interview trail at least when I interviewed for med school, was a pilot. And I didn't talk about it in any grandiose way, but it just was just like we're talking about right now. It's something you can talk about. It has nothing to do with volunteering or grades or MCATs. It's just very unique and different. And so, like I said, diversity of experience. And there's plenty of doctor pilots, by the way. I'm not that unique. And there's doctors in my institution who own planes and fly way more than I do. But they don't talk about it like I do or necessarily reflect on it or write about it. So I get the attention for that. But yeah, one day I want to go back to it. And I can't wait.
You introduce words in there, fun and joy. I mean, those are the things that certainly fill us up and help us get through those times when perhaps we feel the systems are going against us. My final question I have for you, and this is again my perception as someone who doesn't practice medicine. I get the sense that we as a society are in fact doing better when it comes to cancer. You've written that your goal is to move cancer from something we regard as an often fatal disease to something that's more akin to a chronic condition. I feel personally as if you're doing a great job, and as a society, we are doing better. Am I right? Is that fair?
And to be honest, that quote that you just mentioned is something from the 1980s from a doctor named Francesca Thompson, who literally said, the cure is growing old and dying from something else, meaning you make it a chronic disease that's manageable, just like diabetes or hypertension. So yes, we're getting closer. In many diseases, you live far longer, especially screenable things, cancers you find early. So I tell every patient, even if I'm seeing a patient for something unrelated to cancer, say, get a mammogram, colonoscopy, pap smear, PSA. You do the routine, you find the routine a majority of the time, and you find it early. So just finding something early, by the way, means early cure, and that's what screening should do. And one of the most interesting things I have happen in my practice is someone has a mammogram, and let's say they have cancer on it, and come into me and they're crying. And one of the ways after listening to the patient, one of the ways I kind of introduce a little bit of humor and empathy is I say, well, aren't you happy the mammogram worked? I mean, God, imagine we did some screening tests that didn't work and we missed this cancer. And that's a whole different perspective. And they say, oh, yeah, huh? Yeah, I'm like, that's how we do them. We do it because they work. I'm so happy that yours worked and you're here to see me because now we're going to take care of this. So yeah, that just puts in a different level. Like, oh, okay, I did everything right then. Yeah, you did everything right. Good job.
Wonderful.
So I think screening is important, but yes, even in complex cancers now, even metastatic, things that were considered terminal, we have so many tools like genomic sequencing and targeted precision medicine and just better drugs, including immunotherapy and combinations with oral treatments, which we call oncolytics. So the field is burgeoning and it's going fast. And my hope one day is to have not just one treatment or a line, a couple types of treatment, but many lines of it. In other words, you could have 6 to 10 lines of treatment and you go through each one year at a time, let's just say, before your cancer progresses. And you say, all right, oh, well, that one didn't work, or it worked for a year. Here's the next one. This will give you another 10 months. Here's the next one. Here's another 8 months. And if you just keep doing that without adding toxicity or other issues, why couldn't you indefinitely continue that sort of journey? That's simplistic, but that we are getting somewhat closer to that.
Wonderful. Hardeep, in a little bit less than an hour, I feel like you've shown us what oncology is all about. We started by discussing burnout, progressed to moral injury, and for the past 10, 15 minutes, it's been about passion, joy, hope, and your vision for the future. This has been so much fun. Thank you so much for joining us today. You are one of those people who has kind of set up your tent pole on LinkedIn. But before we sign off, there's a few groups over there that you are part of or manage. Just tell the audience best ways to get in touch with you.
On LinkedIn, I'm Hardeep MD, or I think Hardeep Phull MD. I have a couple of groups: a Cancer Journeys group, a Sports Transformation group, and an aviation group called Aviation Hub. And I love sports. We didn't get to talk about it much, but I think they empower human journeys and show empathy and so many other great traits. And you can do it in a very just like physicians can be very empathetic, sports can bring out the best in people, and so can competition. And in aviation, of course, I talk about that a lot and post some really cool posts on LinkedIn. I don't know, LinkedIn is just kind of something that always spoke to me because I like to write a lot. And, Instagram, I write these things and no one reads it. They don't really care. And same with Facebook or Twitter. So, it's a non-political way, kind of a relatively clean platform in today's age where you can post professionally, but still have some funny things on there and posts and things outside the beaten path. So I'm very lucky to have that community, and I hope it continues to grow.
Hardeep Phull, thank you so much for joining us today. This has been so much fun.
Thanks so much, Marcus. Thanks, Tosh.
Thank you.
I'm going to take it out here, gang. The football coach Lou Holtz once said, it's not the load that breaks you down, it's the way you carry it. And cancer, to be clear, that's a heavy load, right? The word has the potential to strike fear into the hearts of anyone who hears it. Yet through the good works of people like Hardeep Phull, we're seeing fear change to hope for patients and moral injury being transformed to resilience for those of us who work in healthcare. You've been listening to MedEdge. MedEdge is brought to you by Metrics, the premier engagement platform for students, residents, faculty, and administrators for both UME and GME. For everyone on the MedEdge team, including Metrics CEO Santosh Cherian, I'm Marcus Grimm. Thank you.